Bueno, quiero darle la bienvenida a todos. Soy Alexandra Cardona y hoy nos acompaña el doctor Mike Ainsworth desde el Reino Unido. Hoy es martes 26 de octubre, pero para el doctor Mike ya es 27 de octubre, así que le agradecemos muchísimo por estar con nosotros. También nos acompaña el doctor Mauricio Echeverry, que nos apoyará en la traducción simultánea, y Joseph Harrison, que es nuestro gerente de ventas internacionales en EthOss. Hace un año comenzamos a dar a conocer EthOss en Colombia y hoy ya tenemos más de 130 procedimientos. Y esta es nuestra primera presentación exclusiva para Colombia. Realmente les agradecemos por acompañarnos en este camino. Nosotros hoy también tenemos que contarles algunas cosas técnicas de este webinar, entonces vamos a ponerlos a todos en silencio al comenzar y vamos a tener un área de preguntas y respuestas. Ustedes en la parte de abajo de su pantalla deben tener esta parte de preguntas y respuestas y al final de la conferencia las estaremos respondiendo. Y para la traducción van a encontrar también un globo en la parte de abajo donde pueden ponerlo en español o en inglés, como ustedes lo deseen. Creo que esto es todo por hoy. Nuevamente, gracias por acompañarnos. Y Dr. Mike, please go ahead with the presentation.
Gracias para todos. I'm going to speak in English now. Thank you for welcoming me to speak tonight. It's midnight here in England, and it's fantastic for you to invite me to share some of my experience with EthOss, and we should be talking today about the tenting protocol. And I'd just like to explain a little bit about who I am. My name is Mike Ainsworth. I am a UK qualified dentist. I graduated from the University of Birmingham in 2002. And I was lucky enough to start placing implants and grafting in the same year as I graduated. So next year I will have been doing this for 20 years. And I started using the precursor to EthOss in about 2006. And I've been using these materials almost exclusively since then. My wife is from Venezuela and she is a Spanish national. So we moved to Spain in 2007 to the Malaga region, and we had a clinic there for a few years. And then in 2011, we moved back to the UK for the English teeth and the English weather and the beautiful countryside, Yorkshire, which is in England in the central region. We live in Sheffield, a place that you may know was where stainless steel was invented, and many of the blades that we use in surgery are made. And we have a specialist referral practice with endodontia, implants, periodontics, and restorative aspects to our practice. And today we're going to be covering the topic of what we are trying to achieve in grafting, and hopefully have a less invasive treatment protocol. Leonardo da Vinci said simplicity is the ultimate sophistication, and this is the principle that we like to adopt when using these materials. For today, if we have time, we will talk about my experiences with synthetic materials, the tenting protocol, some apical surgery with immediate placement protocols, and some interesting large lesions. So in terms of what we are trying to achieve, patient outcome is the main thing. In many ways, we have many technical analysis that we do for implant placement, but all the patient requires is a tooth that functions well and comes from the gum or the gingival very nicely. This interface is what we, as implantologists, clearly want to manage more than other things these days. We want to minimize the trauma, so we would like a single surgical site, minimizing the number of procedures involved in getting to our end result, minimizing the swelling and the post-operative pain, and if we can gain soft tissue without the use of complex periodontal plastic procedures. So minimizing time, minimizing the cost, and we like a high margin of safety. We don't like to have all of our eggs in one basket, as we say in English. So we would like to look at the original protocol. This is assuming that an immediate implant is not practical. We have the extraction, and when I learnt we had 3 months of healing, then we would do our site assessment, and if we could place an implant, we would, but often we had to graft as well at this time. And then we had 3 to 9 months, and then we would place our implants, and then we would begin our restorative phase. The question is, can we take some of these steps away? For example, the first 2. Could we place our implant at 1 month? And can we do implant site assessment, grafting, and implant placement at the second stage using the Fairlev protocol, which was developed by Peter Fairburn and Minos Leventis. And again, restorative phase, 3 months, so this is not compressed. Which graft enables us to do that? These are your traditional grafts. Particulates we favor over box generally because of the vascularization and adaptability and ease of use of particulate grafts. And autogenous bone tended to be the gold standard with allograft, and it's still very popular. Xenografts are very popular, but synthetic materials seem to be able to solve many of these issues without having harvesting or the animal, allergenic, and ethical issues. So I tend to move towards the synthetic materials. An important factor to consider is turnover. So in terms of hydroxyapatite, xenografts, for example, and on one end that does not resolve, and human and calcium sulfate allergenic bone, which does resolve very, very quickly, too quickly, in fact, in many cases. There must be a happy medium in between, and it seems that a mixture of beta tricalcium phosphate and calcium sulfate can work very well. So again, we have to consider other factors in our resorption profile. Stability of the graft is very, very important, and we need to look at muscular pulls around the sites. So which graft do we want? Cow, pig, or factory? We tend to go towards the factory result. So a brief history would be EthOss Vital, which is what was the precursor of the EthOss, which is a similar material, but it was more of an orthopedic product, and we had to modify it many times. And EasyGraft was, again, a similar beta tricalcium phosphate with calcium sulfate, but that had a polylactide coating, which again caused some slight issues in terms of its breakdown and its integration into the body. So this protocol was developed alongside the materials, and it's important to understand that the protocol and the material go hand in hand. And this is an interesting paper that Peter and Minas did in, I think it was 2007, and it describes this protocol. if you want to look it up. Basically, you remove the tooth, and 4 weeks later you have partial socket healing. Quite often you've got quite a significant buccal bone defect, and as you can see, the implant is placed into this defect. You can see the ridge of bone around the socket is not resorbed yet, which is important because this stabilizes our grafting material. You can see here. It acts like a shelf and causes a mechanical lock that the material can hold into. And the implant itself plays a part. Rather than having a very large void to fill with grafting material, the implant itself provides a graft. We can place our sutures. This is silk, which I haven't used for many, many years, but it still worked. And you can see here, long-term results. You have a large gingival cuff, and but sometimes you have the problem of graft stability. If you do not have the healing socket, you may require something to hold your graft material. We could use titanium meshes. They're great at gaining vertical height, but anyone that's ever used these can understand that dehiscence can be a problem, and they need removal. Removal can be difficult and messy, and you can have real problems trying to separate your gingival tissue from the titanium mesh. There's an iGen membrane, which looks very interesting. The bone ring technique was popular for a while, but I don't think that ever really worked very well. I think the gold standard for large defects will remain the Curie plate technique. I must admit, I've only done a few of these, having done the course in Madrid in about 2008. I did a few, and they were useful, but I found it very difficult to limit the post-operative morbidity from the harvest site. And so we looked at CAD/CAM blocks, but these tend to resorb. I don't think the technology is there for the vascularization, and they tend to resorb a lot. And I think Straumann have actually pulled this product from the market in the last few months. So I don't think you can even get this anymore. So the question is, can we make a particulate behave like a block? The sausage technique from Estabilidad seems very promising. And if you look at the paradigm that we all learned about horizontal bone augmentation with minimal gain of less than 2 millimeters can be done with guided bone regeneration and ridge expansion alone. Moderate gains, GBR, ridge expansion with some sort of titanium mesh or block graft, possibly. Then a maximum gain of 4 millimeters, they say, could only really be done with a block graft. And the other thing that doesn't get discussed is what we need to do after we've done this guided bone regeneration. There's removal of screws, second stage implant placement, extra cost, and then management of the vestibule can be an issue. So, looking at the protocol case again, it's very good being able to do this site, but what happens if you have a thin site which has no mechanical retention and you're trying to use a particulate synthetic graft? Is there anything that we can do to aid this? So what do we do in these cases where you have no volume? I saw a paper by Palmo Benfiti, and we looked at it. It was using this polydioxanone suture, which is an Ethicon product. It's used for internal stabilization. And it's a very large diameter. It's 2, 0. The polydioxanone resorbs by a process of hydrolyzation. And so it takes 270 days to actually fully resorb, and it maintains its mechanical properties for a good 3 months or more. This is a very interesting product. And they did a case series using this as a dome device, hence the dome tent analogy, made of a slow, long-lasting resorbable suturing material. The problem is that it was more than a year in treatment with the HA material that they used. Can we reduce the treatment using EthOss and beta-TCP? So this is the schematic, and you can see they used membranes and they used allograft. So if we look at the membrane issue, this is an old Shakespearean quote. It was our wedding anniversary last week, and we went to Stratford-upon-Avon, where Shakespeare was born. And the membrane or no membrane issue is something that has really tormented dentists along the way. Do we place a membrane using these materials is one of the key questions. And the answer is yes and no. We do not place a separate membrane, but then what we need to do is understand what the membrane actually is for. So what it needs to be is cell occlusive. It needs to allow fluid transport from the periosteum into the graft material. It needs to create a mechanical stability, and it needs to develop neoangiogenesis from the periosteum into the graft. Can we do this without a separate membrane is the question. And the answer is yes, we can. The calcium sulfate within the material itself and the geometry of the beta-tricalcium phosphate actually forms a membrane. And the periosteum itself is your membrane. So you don't need an actual separate membrane with EthOss because the material is the membrane. So this is a case that convinced me of the protocol using tenting. The plan was to extract the canine, tooth number 23, using the FDI nomenclature. We would place implants in 24 and 25, 26, and we were going to place a temporary bridge on these teeth and cantilever forwards after we grafted and placed an implant underneath for closed healing in the 23 area, and then we would finalize with a prosthetic. So it was quite a complicated treatment plan because this canine was grade 2, borderline grade 3 mobile, had virtually 80% bone loss on the buccal and the distal, and a very deep infrabony defect on the distal. You can see here that we had a very thin amount of bone, and the 2mm pins were almost coming out of the bone on both the buccal and the palatal side. So if we were to expand these osteotomies, we were going to basically lose the bone covering over the buccal. So I did bone expansion, and we placed our sutures. We did root surface debridement on the canine, and we also removed the granulation tissue and root surface debridement and degranulation in the area around the 3. we placed our grafting material. You can see the suture, and we also filled the infrabony defect and to a certain extent the buccal on 3. Tension-free closure using propylene sutures or PTFE. It's important with these materials that you don't use a vitrectoral or a gut suture, because the resorption of that suture causes giant cell reaction, which will have an adverse effect on your graft. This is 7 days post-op, very large graft, and then where is the inflammation? There's very little inflammation here. And so the sutures, I think, are important. So this is 3 months post-op, and we can see that the canine, which had the very deep infrabony defect, is now completely solid, no mobility whatsoever. And you can see the gingival cuff here. You can see a large hard tissue gain. So this is the gingival cuff. And here, interestingly, is very hard to palpation. In the UK, we're not allowed to take CT scans as much as in the other part of the world. So we can't actually confirm this with CT, but I expect there was bone here. You can see the initial situation with a large inflammatory response and deep pocketing. And you can see there has been quite significant recession, but that looks like healing to me. And you can have a trace of where the tissue is compared to where it was, and the 3D gain. And this is after we fitted it. We modified the treatment plan and just restored these 2 implants rather than doing a temporary and removing the canine. And this is after a few years. I think this is 4 years later, 2017, yeah, 2021. So it looks pretty adequate to me. We might be starting to have a little bit of an issue with the canine again, but this has no probing depth, so, and the canine is still completely solid. So I think this is an adequate result. If we look here, this is a case that was referred to me, and we took a scan. Now, the question we always have on our mind is, how do we deal with this? The tooth has been taken out fairly recently by the referring dentist, and we have a large palatal defect and a very large apical cystic defect, and we need to restore this. In the old days, this would have been probably a Curet plate in my hands. So one of the first things that we consider as a little tip for using the materials that we do, certainly with EthOss, it's very important that frenal pulls are dealt with at the time of surgery. So looking at the flap before you open and looking at where potential movement would be within that flap is very important. A simple frenectomy and tying it off takes 2 minutes and will really help with healing. You don't need to do anything like a Z-plasty. If this frenum reattaches later on, it really doesn't matter. It's just for the 8 to 12 weeks where the graft is sensitive that you want this pull diminished. So in this scenario, you can see that we did a palatal incision, and very carefully, using a busa and a Lucas curette, we removed this tissue, very carefully dissecting down into this, and remaining tissue is attached to the flap. This is important later on. We would place apical first with a wet mix of EthOss, and then we fill the palatal defect also. This was a zero preparation osteotomy. I just laid this 4.5mm drill just to show. So we did absolutely no drilling for this case. And we placed our implant slightly wider than I would like. This is a 4.5mm diameter implant. As you can see, it sits just outside the bony envelope, which is no good. And it's engaging just on the mesial and the distal. It has not very much what we would call primary stability in terms of torque, but actually it was very stable in terms of its dimensional stability. I think the torque values are very much overplayed within the dental implant profession. I think aiming for high torque is slightly, it's a misnomer, really. I think what we need to be aiming for is the implant itself to be dimensionally stable. And as I'm sure you've seen Peter Fairburn show cases where we have zero bone to implant contact and the implant is just placed into the EthOss on its own, and those integrate incredibly well. So this was stable, but it was not, it was secure, but it only had about 8 or 9 newtons of torque. So you can see here, we're outside the bony envelope. And if we just placed our graft material here, we'd probably not get an adequate result. So I decided to tent in this case. This tenting holds the grafting material and it holds the gingival cuff off. And then this is at uncovering at 3 months later. You can see the patient has limited oral hygiene. And you can see here that the implant, though it was wider than desirable, we've managed to get an adequate result. And this is after a year. And this is after, I think, 3 years, and he's actually chipped the crown. So he grinds his teeth, and I keep asking him to come in and have this replaced, but he's a farmer and he's not bothered about that at all. So looks fairly stable. This is a video just showing the technique. So if we're looking at the technique here, you can see we're raising a flap. Now these are degranulation burrs, very, very useful. Coarse diamond burrs to get the granulation tissue away from the wound. This is an osteotomy, very thin ridge. And we can see here, we're using an amalgam pin drill, Estabilidad green amalgam pin drill for a mini osteotomy. You can see it's a step drill, and so it doesn't go very deep. More degranulation. The key to good results with this material is to get back to bare bleeding bone. So you need to make sure that you really do degranulate. And I would say you treat the degranulation almost like you would if you were writing an essay paper. You do a little bit and then come back and revise it later with fresh eyes. So this is the manipulation. You can see it's very stable. So with the placement of the implant, quite often I would place the implant beforehand. Here is a very wet mix to start, and you can see it flows. And we gradually get it underneath, and then gradually a little bit more, building it up. Don't be too greedy with the EthOss. You don't need to put so much in. Then allow to harden. Suturing is important, tension free. And that's that. So it's still in the early stages. It looks promising. There is a lot of technique sensitivity, and the many people that are doing this technique, they do a few and then they get frustrated, and then they do a few more, and it gradually gets better and better as time goes by, and then it becomes more part of your armamentarium as time goes by. The question is, would you get the same results without tenting? I believe not, and experience tells me that I don't think you would get the same sort of results without. It's cheap, it's reproducible, there's minimal intervention, and you can gain vertical potentially. We're looking at new products. I'm working with the University of Sheffield. We have a postdoctoral student, PhD student, and a postdoc working on this for us as well. So this is a schematic of what we do. We use the step drill to do 4 mini osteotomies. Then we place a short piece of the material and we place it into either end, and then you can see over here you get this dome effect, which holds the gingiva off and gives the stability to the EthOss and stops it from slumping. Again, 4 mini osteotomies, and the material just gets pushed in just a little bit into these holes, not too far. People ask if it goes all the way around. It's not. It's this length plus maybe 2 millimeters either end. It's not very much. So this is another case just to illustrate. This was an ankylosis case, and we removed the teeth and basically all of the bone with the canine, which was ankylosed. Again, we placed our implants and we placed the sutures, and placed our grafting material, and as you can see, allowed it to dry, tension-free closure. 4 months later, we uncovered, and you can see here, it's quite important to illustrate actually. What you see on an X-ray with EthOss isn't necessarily what you see in the mouth. This is taken on the same day, and as you can see, this does not look like bone, but I can tell you here that this required drilling away with a round burr. So this immature bone, the osteoid, may not look radiographically as impressive as BioGuide or an allograft made of hydroxyapatite. However, it's vital and it will trabeculate over time. So here is the uncover. You can see a reasonable gingival cuff, and we're not allowed to take CT scans in the UK, so I inferred the growth from measurements from our digital intraoral scan taken, and that's 5 millimeters of gingival cuff. So I'm satisfied that there's something there. So this is the restoration, and that's the before, and this is the after, and that's stable.
De estudio, pues porque eso está por si tú quieres ver tomográficamente cómo queda el implante.
Hello?
Me imagino que es lo que es el cuestionamiento, doble radiación. Pienso yo que sería por eso.
I think we're having a bit of technical difficulty, Joe.
Apaga ahí porque está haciendo esto.
So, can you still hear me?
Yeah, I can still hear you.
Okay. So, sorry. So I'm just going to skip through this. This is a similar sort of case where we used Marco De Giudi's welding, intraoral welding, for this particular case, and as you can see, there's quite a challenging case, and seems to be some lines on my screen that have been drawn. I'm not sure. So this is a case where we decided to take half of the lower teeth out, and as you can see, they're pretty large defects. And taking note of the defect and the bone on this particular part here on the canine and on the central incisor, you can see we didn't have very much here at all, so we placed a tenting suture. This is an immediate placement, and we do have bone here. This is a welded conometric case, and an immediate long-term durable framework was made. You can see immediately post-op, and then this was taken 3 months later. Still actually a little bit of proline just in the tissue there, happily sat there. You can see the defect that we repaired. And interestingly, over time, at 6 months, this anterior defect has stayed stable, but around on the buccal where we had bone, that has started to resolve. And you can see the anterior seems to have preserved the bone, and then the buccal seems to have disappeared. So the journal EDI case, this is the European Dental Journal, and this is published in 2019. We did a similar sort of thing. This was combining a periodontal defect and, again, large buccal defect on the central incisor and mobility in the lateral incisor. So you're combining periodontal and implant care. Again, frenectomy. Look at the muscle pulse on the area in the premaxilla. So significant bone loss and a distal infrabony defect, a mesial infrabony defect on the lateral incisor. So what we decided to do is de-epithelialize the lateral incisor for a coronally repositioned flap and degranulate, clean all of that out. Noted a lack of a palatal wall, so again, preloading with EthOss. And then we actually decided to put a tenting suture in the periodontal site also to try and relieve the tension from there. The coronal advancement wasn't really to gain any root coverage, it was more to gain the soft tissue closure. You can see here, this is what we started with, what we finished with on the day. This is an uncovery. You can see we're starting to get quite a nice little extra bit of keratinized tissue in that area around the lateral incisor. You can see as it matures, it gets a little bit better. And as you can see later on, this lateral incisor has become stable. We still have a lack of posterior support, but the crown around the implant looks adequate, and we have a soft tissue gingival cuff that looks stable. So this is the final. Sometimes when you're using EthOss, you want to place the graft material into a narrow socket or a narrow defect. And this is a technique to utilize a 1 cc syringe, and you can take the end off the 1 cc syringe, and fortunately this fits almost perfectly within the EthOss syringe. What that means is that you can fill your 1 cc syringe and using a booster instrument mixed within it, and then you can place your implant, you can place your grafting material into a socket very nicely using that technique. So that's just another tip. So can we use EthOss in a different way for immediate placements? Rather than extracting a tooth and trying to manage the socket from the through the socket, we can use a technique where you're actually using a Lipke-Oceanbein submarginal flap to clean the area in the same way as you would in an apical surgery technique in endodontics. So this is an active infection on tooth number 11 and tooth number 13. The patient was in the public eye and was adamant that he could not be without teeth and couldn't wear a prosthetic. So we were in a difficult situation as he had had previous apical surgery attempts in specialist clinics and nothing was working. So the site was very challenging and very actively infected. So again, we decided to utilize immediate placement and use a Lipke-Oceanbein flap to try and get visual access to the apical area while maintaining a good gingival cuff and immediate placement. So we used a CAD/CAM mill pro shell with seating wings and surgical guide. This is a SMOP guide. And we also pre-loaded the patient with amoxicillin and metronidazole for 3 days pre and post-op to reduce the infection. The teeth were extracted and the shell was tried in. Then the flap was raised. This was very difficult because of all of the scarring. Placed the implants. This was codometric according to the De Gidi technique. Then we used intraoral welding. And then this is the temporary that was fabricated on the day that was codometrically retained. So it was not screw or cement retained. Then this is 9 months later with a durable temporary, and we removed it, had a look at the soft tissue cuff. And then this is the monolithic zirconia versus the codometric temporary. And then this is the final seating. So the immediate apical technique, what do? We have a tooth that has a clear apical abscess. We remove the tooth. And I think quite a lot of the issue with failures in this particular situation come from not being able to adequately degranulate. So we developed the technique of raising the flap using the submarginal technique, cleaning everything out, degranulating, placing our implant, and then we can place our temporary restoration. We can get that all in, all seated. And sometimes anyone that does this sort of procedure always worry about getting your grafting material if you placed it prior to placing the temporary crown in this area. With this particular technique, you can place the temporary and then you can load your material through your submarginal flap. So you can do this with unusual anatomy, removing interesting looking teeth. So how do we remove this without catastrophic bone damage? Again, you can use the same technique, submarginal, active invection, using normal apical surgery techniques. In this particular instance, I think we used pisotome and removal of the apical portion, then simple forceps extraction, which preserves the bone, full degranulation. We also used dense burrs and did a internal sinus augmentation here at the same time, engaging both cortices, pre-placed our EthOss, and then sutured up so we have a nice result. In certain circumstances, when you have an oblique, very, very thin, narrow oblique ridge, this is a fairly extreme example of what you can do in a single procedure. Again, this would have been quite a difficult case to manage without this suite of techniques. We can treat this almost like a sinus lift on the internal, and so long as we can visualize and retract these vessels on the lingual and manage the buccal using tenting, we can treat these cases very simply. So this is a very thin ridge, and we use an instrument to protect. This is one of the only times I would tend to use a membrane just to contain any graft material on the lingual. And again, everything is done protected by an instrument, placing our EthOss, placing the implant. You can see it's the implant is actually placed with only the lingual engaged. And we can see here at uncovery, we've got bone growing up over the implant. And these slides are slightly in the wrong order, but you can see we tented and then we uncovered and we had bone grown up over the implant at the end. And this is after after about 3 years, I think. So we've had some bone loss anterior to the implant and some bone loss posterior to the implant, but you'll note that the actual bony crests go up to the implant shoulder itself, and it's very adequate in the mouth. And again, large anterior cystic lesions can be treated simultaneously, reducing surgical steps. So we can see here removal of the cyst, degranulation, placement of implants, reloading and placement of the implants, and then this is at suture removal 1 week later. Very simple, very straightforward, single surgery. and this is taken a couple of years later. Obviously, it's not perfect, but I think it's a reasonable result for a single surgery. Again, this isn't style Italiano dentistry I'm performing here. This is everyday dentistry on English patients who just want teeth. So you can see here, quite a difficult defect. And again, this is a CT that I took actually a couple of weeks ago. And you can see that we've got a really nice quality bone here after a couple of years. So again, this is a more extreme sinus case. So how would we manage this? Normally it would just be extraction, waiting, lateral sinus lift, 9 months, placement of the implant, another 6 to 9 months, and then again, going back to our original slides. In this particular situation, what we decided to do is remove the tooth, and we placed an implant with a lateral wall sinus lift, and we placed simultaneously. Now, it's important to note that because of the oblique nature of this particular sinus, we could place immediately. If this was just completely flat and a shell, you wouldn't place this implant. But because the implant was going through the bone and we had a defect behind and in front, but the defect in front was within the sinus and the defect behind was within the socket, the bone was engaging more than a few threads going up through the implant. So this is 13 months loaded. And again, we did a CT scan, and you've got bone just where it wants to be. Not massively filled up in the sinus. And then managed to take a 3-year load, and you can see it's looking very nice. And then another case would be for pontic site development. So you can see here on this case, we previously placed implants, which we were happy with, but the actual pontic sites for the bridge work were not very adequate. So we wanted to avoid on the other side. And so we had adequate bone for the implant placement, but we decided to actually tent in the pontic site to build that up and try and give us a much better result. And you can see here, this implant here was okay, but it was let down by this this site on the lateral incisor. Whereas on the other side, we managed to get a nice implant, actually maintain a nice profile next door. So that's quite a nice little way of doing things. So in conclusion, there is a virtuous circle to using synthetic materials. You don't have a membrane, which means that you've got less volume requirement. You can explore different approaches because you don't have a membrane, and also you're growing vital bone rather than just using blocks and bricks. What that means is that you don't need as much volume, and so you can take your tooth out and simply wait for just initial soft tissue closure. And you get free soft tissue from your granulation tissue within the socket, which can be used to close. And if you can use that to close, there's a reduced need to split the periosteum. So you can cover quite large defects without doing a periosteal split quite often. And so it's a great way of simplifying the process for more general dentists like myself. You know, I'm not a big surgeon, and so this is just general normal dentistry for us, and it's daily procedures. So thank you for your attention, and thank you for inviting me to speak tonight. So if I I can't hear anyone.
Mauricio, thank you for that, Mike. Mauricio, do you want to ask if anyone's got any questions to type them in the Q&A area? Mike, if you want to read out the question in the Q&A and answer it.
Buenas noches, ¿cómo hace para anclar la sutura en las presiones? Yeah, the suture is resorbable. It's resorbable by hydrolyzation, so it lasts about 270 days. So it's not traditional resorbable suture in the way that a vicryl or vicryl rapide would be. It's important because it does not get a giant cell reaction. It just gradually degrades rather than resorbs, if that makes any sense.
We've got another question on the chat as well, if you want to read that.
I can only see one.
Look at the chat at the bottom.
More chat for, okay. ¿Cómo pasa en español? La sutura de la cabra, no sé. No, it's you don't need to take it out. It remains in situ, so there's no second surgery to remove the suture. That's the advantage of this particular situation.
Brilliant. Well, thanks a lot for that, Mike. If we haven't got any further questions, I really appreciate you taking the time to
what material is the tenting made of? Oh, what I'll do, if you don't mind, I will take you back to the, if you want to take pictures of the suture, this is a question that we always have. I'll leave it up on the screen. Can you see that?
Yeah, I can see that.
So it's PDS2, Ethicon. Ethicon are the biggest manufacturers of sutures, as you know. They manufacture Prolene, Vicryl Rapide, and it's just a different type of suture.
Doctor Mike, nosotros también tenemos la sutura en la marca en Colombia, que yo la tengo aquí, la puedo también, no sé si está bien así acercarla a la cámara.
Okay.
This is the suture.
No, I see.
I don't know if this is easy to see, but we have the same suture in another brand.
Okay, right. Yeah, it's I can't see your screen. It's polydioxanone is actually it's not proprietary to Ethicon. I do think other people do make it. It's important thing is the polydioxanone. It's a monofilament. It's injection molded, I think, onto the thing, but it's something that's it's a standard formulation. So other people do make it. I think there's an American company that makes it as well.
Nosotros la tenemos como azucril monoslow en 2.0 y es el mismo material, solo que la marca es la marca suiza azucril monoslow.
Okay, azucril.
Yes, and it is the same PDS too.
Yeah, PDS2, yeah. So that will work. And we're looking at other biomaterials as well that are similar in their makeup for various things at the university. So
no, really appreciate that, Mike. And if no one's got any further questions, also Mauricio and Alexandra, thank you very much. And thank you for everyone that has watched as well.
Gracias
a todos.
Gracias.